This is the video of a right-sided standard cochlear implantation in a 75-year-old gentleman with profound hearing loss on right side and severe hearing loss on the left side. So this patient is planned for a bimodal hearing where he'll be using a good quality high HDR hearing aid on the left side, and we plan to rehabilitate his right ear through a cochlear implantation. This is a normal mastoid with some evidence of a mild mastoiditis with a normal intact tympanic membrane. The plan is here to do a standard limited cortical mastoidectomy with overhanging bony edges and a posterior tympanotomy for the cochlear access via a round window. As you see here, this slightly oozy mastoid because of a little mastoiditis that this patient has. He has been pre-medicated with antibiotics for a week as well as received appropriate pneumococcal vaccinations. Now, once we drill here, initially most of our work is using a standard cutting burr. The point is to create a limited mastoidectomy with overhanging ledges for the electrode array. And while limiting the mastoid cavity, one mustn't really drill a small hole because then that is counterproductive because you need some light to come inside the mastoid bowl into the posterior tympanotomy. Whereas also it must not be too big because then if you take it too high superiorly, then it starts to impeach on the space that is normally required for the receiver stimulator. One thing that has to be very importantly remembered in this kind of surgery is that in standard cochlear implantation, while initiating posterior tympanotomy, one must sufficiently thin the canal wall. However, thin the canal wall, one must also take care as not to thin it to a level that it becomes fractured by a slight pressure. So, while thinning is important, one must thin too much because that can lead to canal wall fracture, and any unnecessarily defect or hole in the lateral canal wall can lead to an iatrogenic cholestoma formation, which can be very detrimental. Once the basic part is done and we can see the shadow of the incus short process, we initiate the posterior tympanotomy using a 3 to 4 millimeter cutting burr. Initially, we use a cutting burr because it's a pneumatized mastoid. It helps us define the sentinel cells which in the posterior tympanotomy cavity. And once we are slightly open, we could probably shift to a diamond burr. Now, actual locating the facial nerve canal and maybe blue lining it is optional, though it is was once publicized in textbooks. We rarely ever practice that, and we follow the most important landmark to follow here is the short process of incus that takes us straight towards the posterior tympanotomy cavity. It's important to maintain the bony ledge that bridges between the short process of incus and the posterior tympanotomy cavity for electrode array to be sufficiently placed there. Now we are using a diamond burr to increase our posterior tympanotomy cavity. One must also be very, very careful not to disturb or injure the bony annulus or the chorotympany nerve anteriorly. We normally don't recommend using very, very small diamond burrs here because they can often just puncture through bone and create a lot of and spend a lot of time in doing that. So here we are using a 3 millimeter diamond burr to just increase our posterior tympanotomy cavity. Sufficiently, it should be made inferiorly so that enough light enters the posterior tympanotomy cavity as well as to comfortably and correctly identify the landmarks. And since our plan here is to use the standard round window insertion method, we want to definitively identify the round window niche and then identify the round window membrane for the standard insertion. As you see here, once we open, we start seeing some edematous middle ear mucosa. This is because of a little mastoiditis that this patient had. It has been treated, but still some amount of increased vascularity remains in such a patient. As soon as we do the posterior tympanotomy, the first structure we see is the stapedius tendon, and that happens to be one of the most important landmarks here, because even if in the absence of a well-defined round window niche, you can almost be very, very certain that your actual round window membrane is located approximately 1.5 millimeters vertically downwards of your stapedius tendon. So stapedius tendon and the stapes happen to be the most important landmarks, because your oval window and the round windows are located diametrically opposite to each other on the basal turn, where the oval window goes towards the scala vestibuli and the round window goes towards the scala tympani, which is our place for insertion. As you can see now, we have switched to a smaller diamond, to a 2 mm diamond burr. And now it's very important to thin the bone over the fallopian canal, because you want all the posterior exposure here. So, and the drill must always be moving with ample amount of irrigation. You see here we're using a large suction bore, we're not using a thin suction. And the diamond burr is not only reducing the bone over the facial nerve laterally, but also medially towards the middle ear, to be able to get enough amount of light inside to visualize the round window niche. One must also take it inferiorly towards the angle of the cora tympani and the facial nerve. So, and because that greatly facilitates the vision inside the middle ear. And you see here how even the slight inflammation on the middle wall of middle ear can obscure the actual identification of the round window niche. And sometimes the inferiorly pointing cells towards the hypotympanum can often be mistaken as actually a round window, where sometimes people may falsely insert the electrode. So when in absence of adequate landmarks, one must always again, like I said, get back to stapedius tendon, as to the fact that your round window membrane or niche is always diametrically downwards 1.5 millimeters below the stapedius tendon, and it should not be sought anywhere else or too far inferior in the hypotympanum, because that is definitely going to lead to problems. You see here that there's a lot of edematous mucosa here, which we are trying to scrape slightly using a sickle knife to be able to identify the niche. We are not seeing a very nice niche before because of the edema here, though though with the use of instruments such as sickle knife, we can at least palpate that there is something like a niche here. We are just peeling off some mucosa here to be able to uh, gather some vision. And now we are using a smaller diamond burr, 1 mm diamond burr, uh, inferiorly onto the palpatory region of the round window niche, inferior to the stapedius tendon, to be able to create and delineate our round window membrane. The round window is one of the most robust landmarks. It's always there. We've seen it especially in the CT that it's there, but just because the mucosal hypertrophy can sometimes obscure it. So even if you cannot sometimes see, you can gently palpate the overlying posterior superior or the superior bone that creates the niche of round window, and a small drill. Like you now see that we have taken a slightly larger drill, because that's much more safer as compared to a smaller drill, which might sometimes puncture the basal turn and create a false tract. So we resort to a larger drill while trying to create our craft our round window niche. It is a good idea to not open the membrane as much as possible, wanting to do a soft insertion in these patients, because once you open the membrane and you drill, that often leads to ingress of bone dust inside the cochlea. So one would try to prefer. As you start seeing now, we start seeing the round window niche and the membrane. Actually, the niche has been drilled, but now we can see the shadow of the round window membrane as we drill more. And I think one must appreciate the size of drill being used here. We are not really comfortable using very small burrs unless we're drilling the crista, which nowadays we hardly ever need to until we are using a pre-curved electrode. So almost all straight sim electrodes can be inserted through a standard round window insertion approach, where one doesn't need to drill the crista, thus avoiding even the slight trauma that happens on the round window membrane. So this is one step where one must have some patience. Usually we keep our drill speeds lower than usual for this step when we are delineating the round window membrane. As you can see now, the membrane is now visible. It's a grayish sort of membrane, not like the pseudomembrane, which is more whitish in color. And a larger burr helps us define it without puncturing it right now. So the puncturing part, we leave it to the end. The receiver stimulator, as you see, has now been placed in the well over the parietal bone. And now the first part would be putting the ground electrode under the temporalis muscle on the bone, followed by actual insertion of the electrode. But before that, we would definitely be instilling some dexamethasone solution inside the open round window membrane. So once you see that the ground electrode is there inside, deep to the temporalis muscle, you can start seeing the round window membrane, which is superior and not the inferior one, that is a hypotympanic cell. Now we use our sickle knife to gently puncture the membrane. You see how the membrane is nicely punctured, open now, and before we actually put the electrodes, we are just using a little dexamethasone to be instilled inside the entire scala tympani before we can actually insert the electrode. This reduces some inflammation, particularly the one that happens on switch-ons. This is a standard 422 electrode, which is half sheathed and is placed facing the modulus. And as you see here, it goes on effortlessly inside it without any need for any further drilling of the basal turn. And once you're removing this forceps, it is a good idea to just hold the electrode a little bit so that your instrument does not pull the electrodes outside. And you see this is a full insertion inside the round window membrane, and this opening shall now be bridged or sealed using a simple periosteum from the post-oral region. The electrode shall then be just placed inside the mastoid cavity. You can see the overhanging edges, which are helpful in supporting the electrodes, and the ground electrode will be inserted deeper inside the temporalis muscle, so as to the fact that the ground electrode sheath should not be jutting out and creating unnecessarily pressure over the periosteum. You can see how we keep periosteum, and again, one mustn't shove too much of the periosteum inside, because then that sort of again blocks the conduction of the electrodes. So one just have to gently insert a little bit inside the round window and not really shove it too deep inside. And be also mindful of the fact that your sickle knife should not injure the electrode array inside the cochlea. So you see here the fact that we have placed the electrodes, and they are now snugly fit inside the mastoid cavity, courtesy the ledges of the bone, and the ground electrode has been further insinuated inside the temporalis muscle bone interface.